Hello, everybody. Good morning here from São Paulo, Brazil. And we have a great meeting coming for everybody. I would like to thank everybody for being here. We have a very special panel today. And to start off, we're going to introduce ourselves. I'm Roberto Takaoka. I'm a dermatologist working at the University of São Paulo at Division of Dermatology, and I'm also the Vice President of the ISED. So I'm going to pass on to our colleagues. We'll start with Peter. Peter, can you introduce yourself?
Yeah. Good morning, everyone. It's also a great pleasure for me to welcome you to this very special meeting that Roberto, together with ISED, has organized. I'm looking forward to an interesting morning, afternoon, or whatever. I'm chairing the allergy unit at the Department of Dermatology in Zurich, where we see a lot of AD patients. I'm also quite heavily involved into AD education and so on. So I'm looking forward to share this half day together with Roberto and all of you.
Thank you, Peter. Jean-François. Okay. I think your microphone is...
Hello, everybody.
There we go.
I live in France, and I am emeritus professor, and I work a lot with the Fondation Eczema to work to share with the patients, especially, and the importance of education. So I will be very happy to be here and delighted to see you and hear from you. I'm sure it will be a very fruitful meeting. Thank you, Roberto, and for inviting me to do that.
Thank you, Jean-François. Merci. Merci beaucoup. And Gail, can you introduce yourself, please?
Hi, everybody. I'm sorry I don't have a camera, but that's for your own good. I'm an emeritus professor. I work in South Africa, the tip of Africa. And my passion in life is to see Africa and people of African origin and in Africa taking over and looking after themselves and driving their own destiny. I have great interest in atopic eczema. My background is basic sciences. I have a PhD, and then I went into medicine. So I've got quite a wide background, and but my interest is eczema. So I'm looking forward to this meeting because it's not just the therapies we use, which seems to be the main thing. It's much more, there are a lot of other things that we need to include in treatment. Thank you.
Thank you, Gail. Yoko, can you introduce yourself, please? Thank you.
Okay, I'm Yoko Kataoka from Osaka, from Japan. And good evening. It's 8 p.m. Japan. I'm a dermatologist and allergologist, and also psychosomatic dermatologist. I belong to the specialized center of allergic center. So I have been met so many severe atopic dermatitis patients. I have been executed for more than 10 years, patient education, data-driven education. So I would like to share my experience. Thank you.
Thank you very much, Yoko, for being here. Let me ask for Fiona to introduce herself, please. Fiona.
Good morning, everyone. And Roberto, thank you very much for inviting me to be here today. I'm Fiona Cowdell, and I'm a professor of nursing and health research in Birmingham, in the Midlands of the UK. And I'm very interested in supporting people to self-manage as effectively as possible. And later I'll be telling you about some of the work I've done with that, which links very closely with a lot of work that Marianne has been doing. We've been working together to try and support self-management of childhood eczema. Thank you.
Thank you very much, Fiona. Marianne?
Hi everybody, thank you so much for having me. I am absolutely not a specialist about eczema at all, but I have been working on a wonderful project with Fiona, and I work for an orchestra, so I have a slightly different perspective to add today, but I'm delighted to be here. Thank you so much for having me.
Thank you very much, Fiona. Oh, Marianne, we're looking forward to your presentation about music and how we can help our patients with eczema. And last but not least, John.
Hello, I'm John Su. I'm a pediatric dermatologist in Melbourne, Australia. I have had an interest in atopic dermatitis before I even started training. Initially it was involuntary, my interest in education, but over the last 25, 30 years, I've found how important it is and how essential it is as part of our service, and we're not often that well trained for it. I'm based at Monash University in Eastern Health in Melbourne, and also at the Murdoch Children's, which is associated with the Royal Children's Hospital and the University of Melbourne. Thank you. I'm really honored to be here.
Thank you very much, John. So I'd like to thank our panel again for being here. This is really amazing that technology can bring us all together, and I think COVID pandemic has made this big change, or made us more connected, I guess, in a way, and made us realize how connected we all are with and how we have to work together to solve these complex problems of, like, for us in the working in a atopic dermatitis area. So I would like to share on my screen with just like to show some slides just for an introduction. We are all here to talk about a very complex and fascinating and intriguing problem, which is atopic dermatitis. We all have these very complex cases, and sometimes they're very difficult to solve. And this is from actually from a cover of the Archives of Dermatology in 1998. It was about evidence. It was when evidence-based medicine was being talked about, and somehow this cover attracted me, and because it described all the factors that could influence our decision making as far as trying to decide which treatment to use for a medical problem. And of course, we have to have our scientific basis, scientific evidence and data and research, randomized trials, systematic reviews. But that's not enough. We have to also consider patient and physician factors, like cultural beliefs, personal values, experiences, education. And something now that I think is going to influence our decision is constraints, as far as especially financial constraints. I'm in, for example, in a developing country, we don't have the same accessibility to medication as the developed countries have. So we have to consider that too. So I guess we will discuss those all these factors in this meeting. And so the organization of care in atopic dermatitis meeting it started in Kyoto, actually, in the ISAD in Kyoto back in 2008. We had a meeting at the Kyoto Conference Center, and we will recognize a lot of people here. This was back in 2008, and we're still here, and we hope to continue having these meetings in the future. And this was the last year's meeting. We discussed the journey of the atopic dermatitis patient, where we talked about decision making and all the problems that the patient encounters during the journey. So here we are. Today we're going to share our different experiences from different parts of the world. We have speakers from Australia, from Japan, from the UK, from Switzerland, and from South Africa. And Gail is going to talk about the continent of Africa, actually. So I think that's my introduction. I would like to ask John Su from Melbourne, Australia, to start speaking about the current status of atopic dermatitis in Australia. John, thank you. And also ask everybody, thank everybody for being here, our audience, and ask if you have questions afterwards, please feel free to write us on the chat, and our speakers will be happy to answer your questions.
Thank you, Roberto. It's a really honor to be here, to be asked to participate in this meeting. I've learned a lot through the ISAT meetings over the years, and I think this is a wonderful, wonderful occasion. So atopic dermatitis in Australia, sometimes I feel a little bit of a forgotten country because we seem to be so far from the rest of the civilized world, but it is a very beautiful country. It is very dry. It varies so much. I went to Ayers Rock about 15 years ago for the first time, and walking around it, almost every quarter was a new landscape. So it is quite wonderful. And of course, we have different types of environments from tropical to temperate. We have a population of over 25 million people now, and about 1 in 30 would identify as Aboriginal and/or Torres Strait Islander. About a quarter of our population have been born overseas. So not being able to speak English well or as a first language is very common, and it is one of the challenges that we face. We do have quite a lot of bilingual people, but of course, English is the dominant language. About 1 in 5 have some kind of disability. We're a relatively urbanized country, although about a third live in remote or far remote areas. And overall, we're quite fortunate from a general socioeconomics perspective in terms of employment. Of course, we do have those who are still suffering from disadvantage and gaps to fill, as we'll talk about later on. We're funded dually, primarily by in government's terms, by state and federal government. And this does allow services to benefit in a way from 2 layers of scrutiny. But at the same time, sometimes it can become quite difficult when both parties feel that the responsibility is with the other. So we do have some private enterprise and individuals who contribute as well. And as you can see from the chart, over a third are managed in hospitals and in private healthcare respectively, as is reflected by the funding. Personally, I'm based in 2 main centres. The Children's is the main paediatric hospital in Melbourne, and we've grown from having no trainees. Now we have 2 full-time trainees, about 12 part-time dermatologists, and a number of nurses and nurse practitioners. Eastern Health is based in the East, which is starting to become a bit like a second CBD. It is a mixed adult and private service and pediatric service, and I'm clinical director there at the present. So we do have a different cross-section of the community. And just what's Australian about atopic dermatitis? I won't dwell on this long, but we have a wonderful group that work with us in epidemiology at at Melbourne Uni, Adrian and Shamali have been doing a lot of work with a number of the other academics there. And we know that eczema is very common. Amongst infants, we're getting a rate of about 30% in one of our large cohorts. And there seems to be some environmental influence, which we have yet to better understand. A lot of the Southeast and the Eastern Asian migrants here have very severe eczema. And of the first generation migrants, we do see an increase. In fact, about 80% of male children, if they have an East Asian parent with atopy, will have eczema. But paradoxically, the parents themselves actually have less atopy. So maybe there's something about that early development phase that's reflected here, working together with the environment. One of Adrian's recent PhD students, Diego Lopez, also made some study about the effects of pollution we're seeing in urbanized areas and effects on eczema and airborne sensitization. And then we also have the effects of our beautiful fabrics here that we're still studying. We did a pilot study that suggested that the superfine merino wool that we see in Australia may actually have some benefits in eczema, and that needs to be worked out. And despite the slightly negative findings of the BEEP and the Preventable studies, we are still working at ceramide-based moisturizers to see if they may benefit preventatively in atopic dermatitis in our patients here. I do need to acknowledge the work of our New South Wales colleagues, Saxon and Gale, who have done a lot on the issue of steroid phobia. And this would suggest that we're experiencing the same problems that many of you are experiencing in Europe, Asia, and in the other continent, and in the US. The effects of family and friends also on the misinformation that gets perpetuated as well. Pharmacists, general practitioners here all have the same issue. About equal numbers would suggest very sparing use of topical steroids rather than aiming to clear it as many as those who might suggest adequate use. So there's still a lot to be done, but we know that education does have benefits. So what has our journey been in trying to educate over the years? For the last 30 years, we've been making some progress with incorporating new materials into our written materials. Yes, they were initially on paper, and as with everywhere, they're now going electronic. We're trying to make more novel ways of presenting them with videos, podcasts, and also with interactive materials. But there's still a lot of work that needs to be done. We follow the UK, I think, in that we do have quite a large amount of our eczema education being done by our nursing staff. As we've alluded to, we do have a number of nurse practitioners in dermatology now, as well as the other registered nurses who educate. And for the last 20, 30 years, we've had group sessions on a weekly basis where we might have 10 to 20 families listening to lectures before they actually see the trainee and dermatologist for more personalized care. It is quite a bit of work and organization, but the patients definitely seem to benefit from this. And then as our staff numbers have increased, we now have more independent nurse-led workshops, and we have about 4 to 5 at the main hospital now per week. Each would see maybe 6 patients or so. There would be assessment, there would be lectures and practical demonstrations of how to apply creams, wet dressings, and so on. As you can see, it's quite a time-consuming process, about 90 minutes for an average patient. And it is credit to the nurses that they have maintained this. We have also had nurses visiting community centers and trying to educate GPs that way. We have found that we do get a high satisfaction amongst the patients and families being treated in this way, a reduction in emergency attendances. But whether this is a time and cost effective measure is somewhat questionable, because there's a lot of resource investment, and we have not noticed any change in waiting time for dermatology, but that may reflect patterns of disease as well as referrals. Trying to train GPs has been a challenge. As mentioned, we've had nurses try to go out into the community to work in nurse-led workshops in large GP practices. And that has had a tangible effect on better quality of referrals and overall better standards of care, and less of the mild disease being referred to the tertiary centres. We've conversely had GPs coming to our clinics, and we did that for quite a while, but we found that was largely unsustainable because of the requirements for staffing and organisation. And I think some of these incentives have taken off, aligned with other state and federal run programs. So many of them have been really attempts at trying to utilize resources to the best of our ability. And it has also served as a means of learning about how we should try to educate better. We now have pediatric trainees coming into our clinics as well for rotations, but it's still a relatively small number that are being reached in this process. So in the last decade, as we are becoming more aware of the number of comorbidities associated with atopic dermatitis, we have tried to tighten our relationships with other specialties and paramedical allied health professionals. So we have tried to have joint clinics, and these have been, again, very difficult to sustain in large centres where we're often governed by clinic space rather than by intention or ultimate care responsibilities. But nonetheless, there's still a work in progress. And it's really the opportunity that we've had to learn from the global experience, which I think has also made a big difference in the more recent years. We came relatively late to the table on therapeutic patient education. We're greatly indebted to the work of ISAD and OPENED in particular, of Professor Jean-François and the Fondation EXMA. And in the last few years, we have been expanding our work with therapeutic patient education reasonably rapidly. We started quite humbly with about 4 to 5 sessions a year. We have not made it particularly age specific. We found that the patients usually had quite a broad interest in wanting to learn way beyond what was immediately relevant for their child. And in fact, a lot of the consultations actually do relate to topics which have no direct relevance to the patients, but maybe it's a cultural thing that we face here. And because of our strong nursing background, we have continued to have nursing education with each of these sessions, as well as guest speakers covering most of the common areas of particular interest. And we have had feedback from the audience to decide what topics to cover the next time. Even though we do have one-off attendees, we have quite a good following now of regular attenders who want to come back for more sessions to reinforce their learning. These are some of our members of our team. Min-Hee Kim was one of our fellows at the time, and she's now a dermatologist and helped us establish this. And as you can see here, we have pediatric allergists, pediatric psychologists, adult psychologists, psychiatrists, ophthalmologists, dietitians, and they've all made it possible for us to cover the areas relatively comprehensively. But it's a huge battle we seem to be facing, because every time we think we've covered something, there seems to be more misinformation that comes through. And we've had some rather heated discussions at some of these live sessions. And we appreciate that the frameworks we're working with can be quite different depending on our background and the type of information that we've come to read. So I think collaborating with each other's professionals, but also we found collaborating with our other professional bodies, nursing, other dermatologists. We've had wonderful support from our college, pharmacists, and we're in the process in at the moment of trying to coordinate an alliance so that we can all speak with a relatively unified voice, and at least what we have that is evidence-based can be announced efficiently. Of course, working with our patient advocacy groups has been critical, and both of our main advocacy groups have been very hardworking in producing new materials on social media. There's about to be a new video series launched with the Eczema Support Australia with one of the celebrity psychologists that we have in Australia, and there's of course an endless amount of demand for education in schools, but trying to sift out authentic demands from less valuable ones can be difficult, and we're working on trying to tighten collaboration between health professionals and the advocacy groups. We've now started, therefore, an annual Eczema Day, which precedes all of our annual scientific meetings, and we have a small organizational committee, but we really don't want to have any special ownership of this, and we're really trying to invite all interested parties, dermatologists and others, to participate in the leadership so that we can really have people's opinions heard, but of course also being vetted to make sure that it is quality and evidence-based. And hopefully we'll be resuming that once we start meeting live again next year. But in the meantime, we have been going virtual, and it's been quite an experience. Our current fellows, Dr. NG and Dr. Younger, have been doing a brilliant job in trying to coordinate this. We've had people coming to our sessions from the Philippines and from places that we would have had no idea that they'd even heard of us. So I think this is a medium that potentially can be very useful and will keep going, no doubt, in years to come. So how do we try to reach out with a more unified approach in the face of this? We still have a lot of work to do. Steroid phobia, this is the topic hop study, which was led by Professor Jean-François. And as you can see, our Australian degree of concern is fairly average. We have started trying to come up with more consensus statements, which are not only for our own college, but to be disseminated to the public as well as to other health agencies. And so I think advocacy from our college has been much appreciated on that front. But in the last 2 years, one of the concerns which has been growing has been that of communities which are simply not getting the education, and particularly the rural communities amongst our First Nations communities and those with disabilities, whether mental or physical. So we've been fortunate with the backing of our college in the last year to have established a full-time rural rotation. It has actually become my favorite clinic to escape the urbanization that is all too familiar and the traffic. And we are ever so proud that we have our first First Nations dermatologist graduating last year. Crystal is now working in the Northern Territory, which as a territory was largely unserved by any dermatologist for many years. Now there is a practice with 3 dermatologists, but there are still large areas of the nation which are yet to be covered. One Queensland dermatologist, Jim Muir, has started an online service to educate GPs, and there are visiting services in South Australia and the West to visit the far remote areas, but the visits, unfortunately, are still quite few. I am grateful that the stirring of conscience really largely came from an ISAD incentive. I was quite embarrassed, but I was most privileged to have been able to attend the meeting, and I'm very grateful for the graciousness of Professor Schmidt, Grundl-Meyer, Takaoka, and Tayeb, for the opportunity for participating in that meeting, where I happened to be in the city and dropped in quite unannounced. But I met some of our African colleagues there, including Gail, and it gave me an insight into how much, as a city-centered Western dermatologist, we are simply not aware of the need that is unaddressed. In Australia, we have interest amongst the ID physicians in scabies and bacterial eradication, which has become endemic in some far remote communities. But the issue of general dermatology, skincare, and atopic dermatitis has been largely ignored until now. So we'll be working together on this in the next year. We're also very grateful for an ophthalmologist, Professor Hugh Taylor at our university, who has done pioneering work in the eradication of trachoma in these communities and has left a template on which we can start building. So very exciting time for atopic dermatitis education for us. And I'm very honored to be able to participate in ISAD, and thank you for attention.
Thank you very much for this fascinating talk, John. I would like to ask Jean-Francois and Peter to moderate the Q&A. Jean-Francois, if you could.
Oh, thank you very much, John. I think your overview is really fascinating because in only not too long period of time, you organized and a new approach in the field of therapeutic education. And I think it's very, very exciting to see the quality of your presentation. And maybe I would like to ask you, in Australia, it's a huge country, and you have a long distance between the atopic school, and probably you also told us that yes, so some people living in island around Australia who will be interested in sharing your workshop meeting thanks to virtual educating meeting. What is your experience? What do you think about that? Do you think that it is possible rapidly to organize a virtual meeting on education in atopic dermatitis?
Yes, thank you, Jean-Francois. I think this is one of the challenges that we would really like to tackle. It is interesting in the far remote communities, the access to soft electronic virtual media is reasonably good, but it's not always in our conventional way. They do have like cafes and hubs where the population who may not have phones or computers can go and access internet. And so it also forms a place of gathering. So our First Nations communities are very, very community-minded, and we have much to learn from that. But I think there is the potential. It's the way of, I think, how we can efficiently and sensitively do that, because learning to communicate is something that is a task that I need to learn myself, and I think my colleagues as well, so that we can, because the values and the cultural values and sort of, I think sometimes the Western mindset needs to be educated first. But it is very exciting. Thank you.
Yes, just another small question concerning the role of your nurses, and I think you organized nurse session. Do you also follow patients using a phone call or maybe small sessions, but personalized sessions? What do you think about that? Because it's not so difficult to do.
Yes. We've been doing a lot of phone calls in the last 2 years, but I think it has taught us how to use that as a possible way to communicate. I think, for example, I'm also using things like the PO SCORAD to try to get severity assessments virtually. And I think these are all very helpful tools.
Okay. Okay, Peter, do you have any question for John?
I think there's a question from Alan Tayeb, and then Andreas also wants to.
Oh yes, I'm sorry.
Raise his hand, but Alan Tayeb is asking, what about Aborigine population versus non-native concerning AD prevalence and severity?
Okay.
Yes, it's a very good question, and I actually want to particularly thank Professor Tayeb for this initiative, because he actually mentioned to me at that meeting, what about your First Nations people? So that has really stimulated a lot of this incentive. Our data is very poor. There are 2 published studies, but the methodology were highly flawed, and they're not reliable. So to be honest, we don't really know. And that is something that we would like to investigate.
Andreas?
John, there is a question from Andreas Wallenberg, Munich. You highlighted the problem of misinformation in your region. Would this misinformation be commercially driven by people trying to sell things that are not needed? Or is it ignorance driven by people who just have other beliefs and background, and they feel that their own content and education would be more important than what is scientifically sound? So how do you deal with it? What's your strategy?
Yes, no, thank you, Professor Wallenberg. This is a good question, because I think the approach is quite different. And knowing what is the root of that misinformation or ignorance, I have not had any formal teaching on this. It is just the pain, I think, of clinical practice over this time for me, that I think listening to the patients requires also exploring what is the root sources of the information or misinformation. And often there can be, for example, even an existential angst that what they're saying, I think, is not really the main concern, but there is an underlying concern, and sometimes even a symbolism of what is being presented, and so if one starts to challenge it at the wrong level, I think we often get into arguments. We have had such an argument in the middle of a workshop once, where a person really strongly questioned our use of medications. We had to stop the meeting and take it to the side. I'm no expert on this, and I definitely value your views and those of all the other experts here. But I think some of these deep-seated things do need a lot of talking through. But at the same time, we need to have some forum where the voices can be heard. Otherwise, we end up with division. So we're hoping that somehow we can have a transparent kind of alliance or something to vocalize what we believe is evidence-based, to still have space that people can voice, but to be able to discuss those at a more profound level. I think sometimes it may be impossible to really reason through, and one might have to give up, but very, very keen to hear the views of others.
Okay.
Okay, I think we have to move on. And Jean-François, can you introduce our next speaker, if you have the program with you?
Yes.
Okay.
I'm very happy to introduce Yoko Kataoka from Japan. And I think you are well known not only in Osaka, but also worldwide. And we are really interested in your presentation because I think Japan is one of the country which is very very interested in eczema. It's probably one of the first country very interesting in its eczema. I remember with Alain Tayeb, we organized a joint meeting with the Japanese society, and it was very, very fruitful. Thank you very much for sharing your experience, Yoko.
Thank you, Saradu. Thank you, your kind introduction. Can you see my slide?
Yes, we can see it, Yoko. Thank you.
Yeah. Sorry. Japanese health insurance system is universal coverage system, and individual payment for adults is 30% in most cases. Adult atopic dermatitis is treated by mostly dermatologists, in a few cases by general physician. Children are treated by dermatologists or pediatrician. We can easily measure laboratory data such as IgE and TAC, serum atopic dermatitis activity biomarker. Most of the healthcare workers and even patients know they tend to have high serum IgE in atopic dermatitis. So AD, atopic dermatitis, is grasped as one of allergic diseases. Topical corticosteroid, TCS, occupies a major part of treatment agent. And for systemic treatment, cyclosporin and recently dupilumab, JAK1 inhibitors are available. As you know, every country has their national guidelines. We have similar guidelines, and we have treatment goal is defined in our national guideline. In our guideline, treatment goal is the goal of treatment is to reach and maintain a state in which symptoms are absent or mild without being disturbed in daily activities by the disease, and drug therapy is scarcely required. Even when this level is not reached, the objective is to maintain a state in which symptoms are mild without rapid exacerbations that affect daily activities. Don't you think beautiful? This is the outline of my presentation. Why we have such an ideal treatment goal? I have to start with a disastrous history. Once upon a time, in 1990s, we had a tragic decade of steroid failure. Many patients had been suffered with severe dermatitis all over Japan. They also suffered with absenteeism, loss of job, and disturbed quality of life, and in some cases suffered with depression. Severe infants without anti-inflammatory agent had been suffered with failure to thrive. They had been often complicated with severe multiple food allergy. The tragic decade had begun with steroid bashing media coverage. People, including healthcare workers, were glorifying these steroids. Atopy business, who intended to earn by selling alternative goods, were rising up. Who is to blame for this decade? Of course, media, eccentric medical leader who just stand based on their own restricted experience are to blame. Additionally, in my opinion, it originated from viewpoint of atopic dermatitis management. We saying from concept of pathomechanism of this disease. In 1990s, allergen elimination was too heavily emphasized, as atopic dermatitis has characteristics of allergic disease with high IgE level. They didn't aware the importance of inflammatory control. Ironically, severe food allergy infants or adults had increased in number because of type 2 acceleration. To rescue this disaster, our first guideline has been published in 2000. Now you can see our history. This treatment goal has been still succeeded through several revisions. As a matter of fact, can we all achieve this treatment goal? Let's see two recent nationwide surveys. This is an ADDRESS-J survey. This is a 2-year observational study to evaluate the characteristics and current treatment of Japanese adult with moderate to severe atopic dermatitis. Was performed from 2017 to 2019. 60% of patients were treated only with topical medications without any systemic anti-inflammatory therapies or UV phototherapies over the 2-year observational period. This is the AD severity at IgA change over 2 years. Starting from moderate or severe at baseline, approximately half of the patients fell into mild or less severity at month 3rd that was maintained up to 2 years. At the end of the study, at month of 24th, approximately 40% were still with moderate or severe disease, and 60% were mild or more clear. What is the difference between good course and bad course? According to analysis, major identified associated factor is patient education. This study also monitored occurrence of flare. At least one flare occurred in 45% in this 2-year observation. This is another survey performed early in this year. This is a distribution by severity of respondent patients. Half of them are moderate or severe. What is the patient's anxiety and suffering? Regardless of severity, a common suffering is that the symptoms of atopic dermatitis are recurring. We have to be aware that patients are suffering not only itching and skin lesion, but also relapsing symptoms. The definition of AD is chronic eczema with frequent remissions and flares. But what is the goal of treatment? Long-term control, long-term good control is required. And we can see the truth of waning and waxing by monitoring of serum TARC. We can see in many cases, waning and waxing is not only the natural cause, but just follows non-regulated inflammatory protein owing to insufficient topical treatment. This patient is a typical case. This patient had refractory eczema by previous doctor's reactive treatment. TARC level shows non-regulated inflammation by previous treatment. On the other hand, I can achieve long-term control by remission induction followed by proactive treatment. By this method, we can maintain normalized serum TARC level. We have to share this fact with patients. In order to solve such problems and achieve treatment goal, we have established our strategy in my institute. Our treatment schedule starts with 2-week hospitalization with remission induction by intensive TCS with simultaneous education. After discharge, maintaining remission status, neither visible nor palpable, and normal serum TARC level, and gradually waning of TCS monitoring serum TARC. In case of failure by TCS, systemic medication is required. This is ultimate proactive therapy, might be called tight control. This is a schedule of holistic education by multidiscipline during 2-week hospitalization. We call them atopic dermatitis courage. We have studied our program since 2009. More than 1,800 moderate or severe adult patients have joined our strategy. Do you remember this meeting in Kyoto? This was our initial motive to establish and continued for more than 10 years. This program achieved long-term maintained improvement of quality of life and also good long-term control of skin lesions with minimum TCS 62%, who showed almost clear control with proactive TCS 6 months later, still leads to maintain good control 2 years later. On the other hand, 37% who didn't achieve good control at 6 months, most of them have poor control at 2 years later. This reveals tight control by conventional medicine improves 60% of moderate or severe patients, but it has limitation for 40% who are candidate for systemic new agent. Thanks to tight control by TCS, we can easily categorize the severe patients if they need expensive systemic treatment or not. After dupilumab introduction in 2018 in Japan, more patients who suffered from previous severe refractory symptoms have begun to achieve long-term good control. According to patient-reported outcome, you can also see obvious improvement in POEM, DLQI, and NRS. Dupilumab is a highly beneficial biologic to improve severe patients' symptoms and signs, but we have to be aware responses patterns are different depending on phenotypes. This shows subtypes of responses. According to POEM score, V-shaped group, you can see at 5th group, it's the most refractory type who needs additional intervention to maximize the effect of dupilumab. Let's move on to the recent survey about physicians' perspective. This is interesting and important survey by Dr. Nakahara from Kyushu University. Patients' total satisfaction are highly correlated with their sense of physicians' comprehension of their disease. And he also clarifies the existence of satisfaction gaps between patients and physicians about numerous each item you can see. And this is another cross-sectional online survey about dermatologist perspective and practices in atopic dermatitis management. Dermatologists feels more or less difficulty in AD treatment, but correlated factors to low difficulty are satisfaction with treatment outcome and motivation to atopic dermatitis treatment and convinced possibility of good long-term control. We can speculate that physicians' successful outcome experience motive the positive attitude to management to achieve better outcome. Virtuous cycle. Now we are planning to educate physicians to increase successful experience in AD management. Now we are recognizing the importance of information control for atopic dermatitis management, and we can expect more appropriate information control by emerging new drugs for previously severe patients. After overcoming the disastrous 1990s, we Japanese have still many things to do. How to realize a treatment goal to all patients? We need education for patients and also for physicians, including good communication and considering budget, maximize the effect of both conventional treatment and new emerging medication. Thank you for your attention.
Thank you very much.
Arigatou gozaimashita. Thank you very much, Yoko. It was a fascinating talk. Oh, I'm sorry. It was a fascinating talk. It's great to hear your experience in dealing with such challenging aspect of atopic dermatitis, which is adult patients, and you managed to do it in a very effective way. So I would like to maybe pass on to Jean-François. Also, I would like to acknowledge our colleagues from the ISED who join us here in the panel. Of course, we have Andreas, Dirk Jam, and Danielle Marcoux is also here. Mette Delerin from Denmark. Alain Tayeb, our president, is here. So if any of you want to have a questions for Yoko, please. Jean-François?
I was really impressed by your talk, Yoko, because I remember I was in Kyoto in 2008, and it was at the beginning of education progress, and I see the very the long distance you have to today arrive to a very mature approach of education. And maybe one question I would like to focus on the effect of dupilumab treatment. Do you think that the arrival of new biotherapy will modify our approach, our educative approach? So maybe, do you think that we only have to focus on severe form or not? What is your feeling about that?
Yeah, I know, as I already mentioned, dupilumab has a good medicine to improve their symptoms. And talking about education, we have no need for the education after dupilumab.
No,
I don't think so.
No,
because
I agree with you.
Yeah, I don't think so, because dupilumab is so expensive drug.
Yeah.
So in my opinion,
yeah.
we have to be specify the need for who is required dupilumab or not. So at the start of treatment, we have education. We have to educate patients.
I appreciate your feeling, because my question was because in France, especially after the first study about the use of biotherapy in psoriasis, for example, some physicians said, "Oh, finally the biotherapy are so miraculous that then we have to only treat severe form of psoriasis patients with biotherapy." So it's not my feeling at all. I'm sure that we need to increase, to improve the education, not only of patient, but also of healthcare provider and sometimes physicians also. So thank you very much to highlight this role of education.
Thank you very much, Yoko. I think you're running a little late. I'm going to pass on to our next presenters. Actually, I'm going to, yeah, they're both from the UK. Fiona Codell is a professor of nursing at Birmingham City University. And she'll be followed by Marianne Barakoff, who's going to present the Dragon in My Skin project. Fiona, thank you very much for being here. I'm going to pass on to you.
Thank you very much. So I'm going to talk to you about knowledge mobilization to modify mind lines and improve childhood eczema care. I have to say this study is quite different from the others that we've heard about. It's set in primary care. So 97% of children with eczema are treated in primary care in the UK. And a lot of the people that I'm targeting will never have even been referred to a dermatologist. So I think that explains quite a different approach. So evidence-based practice, we all know it's something that we should be using, but we know that research takes a long time to get into practice, and that a lot of our efforts are about just pushing knowledge out and telling people what they should be doing, and that has very limited success. So knowledge mobilization is a particular area of interest for me, and it's a different way of thinking about how we promote best practice. So one definition of knowledge mobilization is sharing knowledge across different communities with the explicit intention of catalyzing change. And that's a really important thing that's different from dissemination, which we're very, very good at. We don't necessarily think when we're publishing work or presenting at conferences how we're going to try and catalyze change. So that is knowledge mobilization. And
excuse
yeah.
me, could you have your full screen in your presentation? Maybe
it's interesting. I can't actually. Oh, hang on. Let me see if I can see it.
Yeah, it should be on the right around there. I cannot see it either. But otherwise,
no,
it's fine. We can see it, but we can't see it. It's a little small, but we still can see it.
Can you see it?
Okay?
Yeah. I don't know where it's gone. So
don't worry about it.
Okay.
You can press F5 on your keyboard and then move to the further slide. Perfect.
Better.
Thank you.
Thank you. So knowledge mobilization, there are many, many different approaches. In fact, there are at least 47 models. And when I started looking at knowledge mobilization, a lot of it was quite esoteric. And as a nurse, I found it quite difficult to think about how I could actually apply it in practice. And then I came across this idea of mind lines, and it's quite a complex idea, but I will try and explain it to you simply. And mind lines are derived from something called the Seki spiral, which is the work of Nonaka, who's a Japanese business guru. And what Nonaka suggests is that knowledge and the way we use knowledge is complex, but starts with socialization and tacit knowledge. So that kind of knowledge that we have that conforms with norms of where we're working. So if you can imagine joining a general practice and everyone treats eczema in a particular way, you're likely to take that on board for yourself, and that becomes your practice. And poor practice can be perpetuated, as can good practice. So we have this tacit knowledge which can be externalized, and it's important we talk to each other about our practices so that we understand what we're doing and why we're doing it. So you externalize knowledge, and then you have an opportunity to combine it with some of the explicit knowledge that you would have in things like the guidelines. So, for example, we have very clear guidelines developed by the National Institute of Health and Care Excellence on treatment of childhood eczema, but they need to be combined with the reality of practice. And then we go for a process of internalization. So you've got the knowledge from practice, knowledge from experience, learning from patients, plus the evidence-based guidelines that then hopefully become internalized to actually drive day-to-day practice. So that's the Secchi spiral. And then John Gabet and Andre Lemay, who developed the idea of Mindlines, have taken that a stage further in recognizing how important it is for this knowledge to be contextually relevant. So each practice will have its own context. So practices, you know, depending on the demographics of the patient population, all types of things will influence the actual context in which you're working. So when you're internalizing knowledge, you have to have practical and usable information for the context in which you're working. So that's the notion of Mindlines. So what I wanted to do was find out how eczema Mindlines are actually created. And to do this, I went out into practice and watched and talked to people. So, and I did this work in a very poor area in the Midlands of the UK. And just to give you a few highlights of these Mindlines. So this is patient Mindlines. And what they were telling me about is just the sheer overload of information, the conflicting information they got from different practitioners, their limited confidence in how to judge the quality of information available. And if you only have to look at the internet to see just some of the awful information that's out there, the amount of trial and error of treatment, which is represented by this dustbin, the amount of influence from family and friends. So their practitioners could tell them one thing, but then following a consultation, they quite likely go out and talk to other people and decide that the doctor wasn't giving them the best information. And their lack of confidence in primary care practitioners' knowledge and skills in terms of eczema care. Those are just a few highlights. Now, this side is the practitioners' Mindlines, and they consistently told me that eczema was a low priority condition for them to treat. They saw it as simple, you know, same treatment for everyone. They had really limited desire to update their knowledge. They were limited by local formularies, so there was only so much they could prescribe. And they saw eczema treatment as a sort of recipe book, topical steroids, emollients, and that was about as far as they went. And I don't say that critically, you know, they've got so many conditions that they've got to manage, and eczema is not right up there in terms of the most important ones for them. So there was a need to try and think about how we could change mind lines. And although the original work looked particularly at medical mind lines, it was really clear that patients have an equivalent. So what I did was set up 3 co-creation workshops with 25 people. So I had practitioners, nurses, doctors, pharmacists, and then parents of children with eczema, some slightly older children with eczema. And we spent 3 days together thinking about what knowledge needs to be shared, who needs the knowledge, and how it could be shared. And because of the nature of these, the target being primary care and people with mild to moderate eczema, they came up with 5 key messages, which are here. So it being more than just dry skin, it's not a condition that will just go away. The need for consistent use of moisturizers, steroids being okay when you need them, and you knowing your child's eczema best. Those messages needed to be shared across communities very widely to try and get sort of level playing field of understanding and shared language. So to share these messages, I went back to actually Japanese work and the concept of bar, and I took that in perhaps not the most purist sense, but I took it as a place for meeting of minds, shared understanding, shared language. And just to tell you about a couple of things that I did. So this is the area that I worked in, and it's a very densely populated, multicultural, poor district in the Midlands of the UK. So I was really keen to try and get density of coverage of these messages in a very small area. So activities that we did included things like going into health centres in the area. We targeted 3 big health centres, GP practices, and did bespoke mind-line informed eczema sessions. So what we did was get together GPs, practice nurses, pharmacists, and I took in a couple of really super expert dermatology nurses, and we got practitioners to share recent experiences of consultations with parents or children with eczema, and worked through how that consultation could have been, why it was good or how it could have been improved. So it wasn't about just going out and educating people, it was about working with them on real clinical cases. Similarly, we went into community pharmacies because they're highly influential. You know, if a GP prescribes topical steroids, and the message then from the community pharmacist when they hand over the prescription is that, oh, that's really, you know, dangerous stuff, that's going to alter what parents choose to do. And just one more example, we went into a shopping centre, again, with 2 highly expert dermatology nurses, and did face-to-face consultations. We did 90 consultations in one day in one shopping centre. all people who were worried about eczema, and the nurses were able to immediately share the messages and help them with their concerns. And there was something really powerful about the nurses being trusted and about the immediacy of help. That's a really quick overview of quite a lot of work, and I'm delighted to say that the work was supported by our National Eczema Society and the Royal College of Nursing. I've also worked continuously and closely with the University of Nottingham, and after the dense coverage of messages, I started working with Symphonia, which Marianne's going to tell you all about, but that was another element of the same project, which was supported by a fellowship from National Institute for Health Research, which I'm forever grateful. But I'm going to hand over to Marianne now to tell you about a more creative element of the project, and then we'll take questions together at the end. Thank you for your attention.
Thanks so much, Fiona, and I will just quickly share my screen. So thank you so much for having me. It's a pleasure to be here. So I'm Marianne Barraclough, and I am the Deputy Chief Executive for Symphonia Viva. Symphonia Viva is an orchestra, and we're based in the UK in the Midlands. We give performances as you might expect, but we also do lots of work in communities across the UK. The projects that we run often involve us asking young people or older people to be creative with us. So to make new songs and instrumental pieces and to perform them together with the orchestra. I was introduced to Fiona back in November 2019, and we had our first meeting in January 2020. At that meeting, Fiona shared her 5 key messages, and we discussed various approaches we could take to coming up with a really creative way of sharing these messages. We wanted something that appealed to the youngest children and their families, something which was engaging and enticing, but which absolutely had Fiona's 5 key messages at the very centre. So initially, our approach was to commission an author and an illustrator to create a storybook with the 5 messages at the heart. Actually, I remember the first conversation I had with the author, Hazel. It seemed quite an unlikely brief. Can you write a story about childhood eczema, but keep it fun? So we had that discussion, and alongside that, we designed a project to be run in a community in Nottingham, working with school groups, which would have culminated in a performance of the story with songs alongside it that had been written in response. It would have been a lovely project. But the COVID-19 pandemic stopped that project before it had even really started. And as a result of the pandemic, we had to think differently. And actually, it's led us to a much more exciting project, which has had a considerably longer, wider and deeper impact. We did commission the story. Writer Hazel Gould and illustrator J. Nolan Latchford worked closely with Fiona in the development of The Dragon in My Skin. They worked as a team to ensure that the 5 key messages remained central to the story. And Hazel brilliantly came up with the idea of a dragon, an equally endearing and fierce creature that is perfect for something that flares. It's a creature that children are familiar with, often have quite mixed feelings about, but generally fictional dragons end up being much loved. The story is a journey taken by children, each with matching dragons, through the ups and downs of life with eczema. When the dragon flares and is fiery and painful, the children want to fight their dragon by scratching, but they come to realise that that will not make their eczema go away. They learn that they need to look after it instead. The story powerfully validates the fears and frustrations that children with eczema can find very difficult. So alongside the book, we still wanted to connect with children with eczema. So we took the project digital. In January 21, we brought together young people with eczema and their families to take part in a series of online workshop sessions. The sessions were led by author Hazel in partnership with songwriter and singer Abimaro Gunnell and supported by musicians from the orchestra. All the sessions took place on Zoom, and in fact, we've never actually met the participants that worked on the project apart from on screen. During the sessions, we took the book, we explored it, delved further into the emotions at a range of points throughout the story. And together, the team, young people and families, created the songs which went on to form the soundtrack for a film which goes alongside the story. Together, the group wrote words and then came up with melodies. So this is a really good example of it. We took this page where everything's most painful and fiery and angry, and the young people and families came up with these words, just little snippets, things that they felt when they read this story. And we then, the Sinfonia Viva team, then stitched these all the different ideas together. The songs were orchestrated, and we had a socially distanced recording session with a small orchestra from Sinfonia Viva. Abimaro added her vocals, and then these recordings that we made of the songs that the families had written and the young people had written were shared back with them. The families recorded themselves singing along to the orchestra on whatever devices they had at home. And then they shared these with us. And as well as singing the songs, the children also recorded their voices reading the story. And then we pieced together all the elements of the story and song to create the soundtrack. We asked everyone, in the final session, we asked everyone to share what they had felt about the process. And these were some of the words that they shared. There was a real sense of connection made. And whilst we only worked with about 15 people in the workshop sessions, they all felt so invested in the project. Alongside this, we worked with animators Abby Canning and Darius Powell, who took Jay's illustrations and animated them to work alongside the songs and the story that the young people with eczema had created. And so this all came together into a wonderful recording, and I'm just going to share a little clip of that now.
I have a dragon who lives in my skin. It is my dragon and only mine. It won't hurt anyone else, but sometimes it hurts me. I don't like this dragon. I will fight this dragon! Today my dragon...
I'm actually going to pause it there. Sorry, that's a cruel thing to do. But I'll share the link to the full film directly afterwards. The initial reaction from families and from the families we worked with and our guests that came to attend the premiere screening of the 12-minute film was wonderful, with many stating that they felt it really validated their children's experiences and feelings, and that they felt kind of seen and understood. So alongside the book and animated film, we worked with the teacher training team at Birmingham City University to create a cross-curricular resource pack for primary schools targeted at the youngest children to raise awareness about life with eczema and to encourage self-care and understanding towards others. The resources are designed to work across the curriculum. The Dragon in My Skin truly does speak to the whole class. It delivers key messages about self-care to those who have eczema and better understanding to those who don't in a really relatable way and without the need to single individuals out, something which parents of children with eczema felt really strongly about. The full set of materials have been shared widely with new trainee teachers and through a range of different education partners, and we hope to continue sharing these resources over the coming years. The fact that the children's voices are reading the story and singing the songs is such a powerful and important element. They really felt what they were singing, and that had an impact on them. They were able to share their own experiences and feelings, but it's also having a broader impact on a much wider audience with children they don't know, hearing their stories and voices, telling them about their experiences. Practically all the resources, the digital copy of the book, the film and educational resources are all housed together on our website, on Birmingham City University's website and on Nottingham University's website as well. And we're thrilled that we've been discussing taking The Dragon in My Skin international, and we've recently had funding confirmed through the Eczema Foundation for translations into French and Brazilian Portuguese. We will be working with locally based organisations in France and Brazil to create new translated versions of the film, which feature young voices from each of the countries, so that we get that same feeling of young people who are affected by eczema being part of it. We're utterly delighted that this project, which shares such important messages about eczema and self-care, has been received so positively, and particularly that the impact has been so much wider as a result of it being a digital project, something which we simply wouldn't have done if it hadn't been for the pandemic, forcing us to think differently. I'd encourage you to have a look at the full film, and I'll also share a link to a documentary that was made in the process. So I'll invite Fiona back and we'll take some questions.
Marianne.
Yes, thank you very much, Fiona and Marianne, for this an encompassing project with everything, with both Fiona's mind lines and the 5 key questions, 5 key ideas, and so I would like to open for questions. If just for does anybody have any questions? I think Alain had a question. Alain, do you want to speak? You had a question. Let's see if I can find it here. Oh, yes.
I can activate my sound system. So I had a question. I think it is in writing in Q&A, and it's about because as you showed that it's like a network of influence between the fake news we need to fight and what is evidence-based and what is based on normal evidence from practice also. And because of the crucial importance now of social networks, I was asking if there was in the because of your perception of this, how to change this this kind of circuitry. If you have influencers, professional influencers, or nurses which are professional influencers in this field of educating correctly the patients with atopic dermatitis.
Yes, that's an interesting question, and I think the key thing that we need to influence is this fear of steroids, and the Centre of Evidence-Based Dermatology have just completed a review of safety of topical steroids, and I know they're going to do an enormous amount of work in pushing out messages from that. But it is a very real problem, and it's one that came up very much in my co-creation groups. And our attempt was to get a sort of density of messages across a defined area, so that everybody was giving the same advice. But it's a problem wherever you go, I think, trying to get. We were aiming for shared understanding, shared language, to try and get the right evidence between different communities, really.
Hello from Iceland. I just want to thank you all for lovely presentations. Short question to Marianne. I'm really impressed with your project, and I wanted to ask about if the book and your project is available online to look at and share.
Yeah, so I've just popped in the chat links to the films, and I'll grab a link to the book as well. Yeah, the digital book is available online, all of the resources, yeah, and the films. So yeah, I'll pop another link in the chat so you can access those.
Thank you so much.
Here's Peter. Congratulations. I think it's a very interesting work. I just wondered how consuming it is to go to other languages, because of course one is the speaking, the other are written words and things. You have an idea about time-wise and also financially wise?
Yeah, it's not totally straightforward. It sounds like a really easy thing to do. You can just translate the text, but in order for it to have that impact, and we're talking about on young children, it obviously needs to be re-recorded. So we're working with France and Brazil at the moment to kind of look at that process. I can't tell you exactly how long it's going to take, but I think it's definitely set up and we're going to be able to do that. So I think if anyone is interested, obviously would love to talk further about that, and we can keep you posted on how it goes in terms of getting it into French and Portuguese. Yeah.
Jean-François, I'm sorry.
No, go ahead, Jean-François, and then
Yes.
Gail has a question.
I think I was really impressed by the demonstration, your demonstration, and we are working all together with you to translate, and not only translate, but to guarantee the same approach that you developed in English language. I would like that highlight that for the first time we speak about atopic dermatitis, not only scaring people with terrible images or very scary story, but with this dragon. This dragon is the two faces. One is the impact of the dragon of the life of the child, but also the possibility for the child to live with the dragon. And I think that is a very positive approach, more positive than given some so terrible story on atopic dermatitis. So I'm sure that it could be very interesting to obtain on maybe an international version for that, and I hope to obtain that probably during the next months.
Yeah, it's good to hear you say that, and I do think that there's an enormous amount of credit due to our writer and illustrator for the way they've created the story. because the brief that I gave them wasn't an easy one, and for them and for Marianne to be able to interpret that into something usable, I think is fantastic.
Thank you. So
there's a questions from Gail and then Peter. Gail?
Hi, thanks for a very nice and interesting presentation. I'm going to ask you from a purely cultural point of view, are you sure that this is acceptable to all cultures and ethnicities and their approaches to health and how they see health? I mean, it's all very well talking about living in England and doing it and going across to Europe and going across to modern countries. What about, I don't see, I'm asking you, have you got anything from other countries or input from other places? Because when we were working in home, the children's one they wanted to use for children had a little dog in it. And I remember one of the people coming from Asian countries said, you know, dogs are actually considered have a bad connotation to them. It's not the sort of thing we would like to use for children to answer home questions. I'm asking you, have you thought anything about that? Have you got people working with you who would help you to do something that is more acceptable globally and culturally and ethnically? I'm not saying racially. I don't mean race,
Yeah.
I mean culture. Okay.
It is interesting. We did give thought. The original work was, we were thinking essentially UK, but we were careful about having different ethnicities represented in all our materials. But as we're working with Roberto and Jean-Francois, we are being sure that we think about cultural appropriateness in the work that we do. So there is going to have to be some adjustment to make sure that it still works. It won't be just a literal translation. So we're working with people with a good local knowledge and then backward and forward translating to make sure that it still works, but that it meets the needs of different groups. But yeah, it's an interesting point. We didn't start off with a particularly international mindset for it. I don't know how differently it would have come out if we had, but it's a very valuable point that we are considering now. Thank you.
Peter, do you have any question?
Yeah, it's more a comment. Just I also think, like Gail, of course, different culture have different animals. In Switzerland, we had a 19-year-old boy. He made a movie about his disease AD, and he chose a crocodile because and he learned to live with the crocodile. Before it was biting and everything, and at the end he knew how to deal with the crocodile. So the dragon might be not that wrong, but of course it depends on the setting. But this young guy, he won several awards for. He made a 10 minutes movie about it, and it was really very well accepted by many people. But like Jean-Francois said, I think we have to give the positive message also that you learn to go with that.
Peter, following your comment, I would like to pass it on to you because you're presenting about the current status of AD in Switzerland. I would like to thank Fiona and Marianne again for this fascinating talk and approach to atopic dermatitis. And so Peter is going to present about Switzerland. So you tell me if you see already my screen. We can see it.
Okay. So thanks for the chance to speak a little bit about the Swiss experience, which might be not so different from other countries, but for sure different what Gail later will tell us. If you think about Switzerland, maybe you may think about mountains and so on, but of course that's more how it's Switzerland. That's where we work now. Our outpatient clinic is at the airport, and people love to come here, although there's much less flights, but we are also much more urban society than a mountain society. We have a lot of AD. I think you all know this, I can skip. Something I have to say, of course, we are a small country surface-wise, but quite densely populated. We have now 8.6 million inhabitants. We have 4 official languages. 3 of them are also in written: German, French, Italian. And of course, we are also, I cannot say different, we are a rich country with a social product of 700 billion Swiss francs, around $650 per habitant and year. And if you see here, we have people who have a low income, but many of them are quite healthy and wealthy. And what the annual income in Switzerland is 60,000 Swiss francs, so about $70,000. Also here we are top in the ranking. Of course, our life costs are also much higher than in a country where the living costs are lower, but this may explain also the access to drugs and everything. On the other hand, we are also an old population. We have 20% almost of the people are more than 65 years. So, and about the same amount is below 20 years. And of course, then is the large part is in between. But this, of course, we don't have a pyramid anymore. We have a tower of age, which is quite flat all the way up. And that has also an impact, among other aspects, that we have quite a costly health system. In Switzerland, on average, we spend $740 per month an inhabitant. Of course, some cost much more, some cost much less, and this cost is increasing. And one major aspect of this is the more and more elderly population. If there are comparisons, I take the comparison with the United States, as they also have very high health costs. I could also have taken UK and so on. Switzerland is a little bit lower, but still very expensive. The big difference is that everyone in Switzerland, by law, has a health care, so a basic insurance, which he pays himself. If he doesn't have enough money to that, the government helps him to pay enough. So everyone has a health insurance, but the insurance is given by private companies, not by the government. So we all have private insurance companies. People pay to this company, they can select and so on, and you pay per person, not as a family. And the costs you pay depends on your age, on your income, on whatever. There's also some insurance model you can select. So the most important is whether you select the model with a gatekeeper. That means you go first to see a GP and then a specialist. I can tell you that's only about 5% of the Swiss population who selects this. And you can also select how much you're ready to pay yourself before the health insurance starts to pay. So this amount, if it's very low, you pay a lot per month to the insurance. If it's high, some people go up to 3,000 Swiss francs they pay themselves, then they have much lower monthly rates they have to pay. So that means also that small expenditures, like for Switzerland, small expenditure, 300-400 Swiss francs, people often decide to pay themselves and not to go to the insurance. But if it comes, of course, to more expensive treatments, then this is covered by the insurance. We have a lot of doctors. We have 37,000 physicians. So we have about 4 physicians for 100,000 inhabitants, which might be very different in your setting, with a higher concentration, of course, in cities, but even on a rural level, we still have a lot of doctors. Most of them are GPs, pediatricians who also see a lot of AD, and dermatologists. We have about 600. So one dermatologist serves about 30 to 40,000 people. In a city, it might be only 20,000. We have also allergologists who care a lot for people with AD, and especially in infants, pediatricians, they really take care of the children. Most of the doctors work in private practice, some in hospitals, which may be public or private sector. Very few work for of government and so on. We have a different separation. So as I said, the very infants, they are mostly seen by the pediatricians, sometimes by pediatric dermatologists, which are more and more established now, and not so often by the common dermatologist, while adolescents and adults, especially in severe forms, are seen by the dermatologist. So the prevalence, I guess it's comparable to other countries. It's more common in children, 16 to 18, depending on the structure of the city, 20% adults, about half of these numbers. And as I said, the children are mostly seen by pediatricians. Only if it gets more complicated, they are seen by pediatric dermatologists or general dermatologists. So we see only the very severe cases from infants. The adults, it's about 2/3 by GPs. If it gets more severe, to dermatologists. The patient can select himself whom he want to see. So actually they prefer to go directly to the specialist, but dermatologists and especially pediatric dermatologists have very long waiting lists. So often they go in a first step to see the GP, and if it doesn't get better, they get to see the specialists. The treatment, of course, is full of novelties. We are based on the European guidelines with the stepwise approach. Skincare we promote, of course, but for the severe forms, we have quite a bit available. We have Dupilumab, which was published in 2017, and from that moment on, it was also licensed in Switzerland. If the patient fulfills some criteria like large severity, if he had other immunosuppressive systemic drugs, if he's older than 12, it's fully reimbursed by the healthcare system. So we have to write a short letter, which is already prepared. We just have to tick to the health insurance if the criteria are fulfilled. Dupilumab, which is quite expensive in Switzerland, more than 1,000 Swiss francs per month, is fully reimbursed for these patients with severe AD. We have other drugs. Now we have already available one JAK inhibitor, baricitinib, which is licensed since April. The same criteria to get it access to all patients like Dupilumab, and we have other drugs that will come in the next months. So it's a little bit different from UK, from the rest of Europe, because we have our own health, let's say, regulatory system. We have Swiss Medic, which is not based on the EMA. So therefore there are some differences, but in general, we are quite comparable to Europe. Research is ongoing in Switzerland. We have mostly basic research, for example, at the Swiss Institute of Asthma and Allergy Research, where you see this very nice review on barrier. And then we have some pediatric allergist dermatologists, which look a lot on the impact of prevention of AD, probiotics, functional food, and all these kind of things. Well, that's the paper I mentioned. For sake of time, I will not enter it, but it's really worthwhile to go into this paper on barrier. And we have a cohort where 3 centers in Switzerland and 2 centers in Germany have now collected a bit more than 1,300 patients from all age group, where we really look at them in the follow-up over 5 years. And we collect quite a lot of things: serum, skin samples, biopsy, microbiome samples from skin and stool, and we are continually analyzing this. And we have already quite nice insights. A lot of data is available and a lot of samples, but this is ongoing. Then, of course, we all know there are differences also in the immunological feature, and we started the collaboration. This is the link to Africa with Emma Gutmann in the States, Switzerland, and our colleagues in Tanzania, where we have the small cohort in the beginning from AD patients. And in Tanzania and Switzerland and healthy controls, we found some quite interesting insights in this pilot group. Now we have the ethical permission also from Tanzania to go for much larger group. We'll go up to 100 patients to compare them, to see really with modern methods, proteomics and so on, where there are the differences in these patients in regarding of immunology, sensitization patterns. We think this is important as these very tailored drug therapies like biologics, which address some cytokines, might work different. They could work better, but they could also work less in populations with a different ethnic background. Maybe Gail will comment on that later. And of course, education also plays an important role. We have different approaches. We have worked very closely with a patient organization, AHA, Swiss Centrum for Allergy. They have a very good network where they co-work with the university centers, but also dermatologists in practice. And we offer training for parents of children affected. This is a training which you can go for 1 or 2 days. You can go evening courses, online courses. Usually this is composed by a dietitian, a psychologist, and someone from medicine. People have to pay for it. You see, $22 per day. That's about the income of 1.5 days work. If someone does not have the possibility to pay, we have grants to cover it so he can attend this for free. We also, this is the movie I mentioned, The Crocodile, by this young guy, which is really very touchy. It's in German, therefore it might be not so much of interest for you, but I was really impressed what this young guy made out of it, and we show it to other adolescents at that age. We have also courses for this age group, but because you all know they are different from adults, they want to party and all these things, they want to be free. If you are affected in the face, this is a problem at that age because you want to find a boyfriend, a girlfriend, or whatever. So we offer also training for them. We have training for children who have the disease. This is of course shorter. We play with a boy and a small dog. They are called Phil and Bo, and they also play together. Phil has the AD and Bo is his friend. In Switzerland, dogs have a very good reputation that, as we heard, might be different in something. These children love these courses also. They learn a little bit how to deal with the disease. They have an age between 4 and 8 years old. And we have also for affected adults training courses. This is usually shorter, 1 day, an evening, online. Online, we started with the COVID pandemics, but we will continue it as we see a high demand on it. Also, these people have to pay for it, but we can reimburse them with grants. And there are also camps that are offered for children and adolescents with AD or with asthma. It's 1 week, so they like to exchange with others who have the same problem, but maybe different solutions, and these are very highly awarded. They are also supported by grants. They have to pay a little bit, or their parents, but it's much covered by grants which we get from AHA, and those get it from the government partly and partly from industry. And locally we offer also face-to-face consultations for the patient, so he can sit together with a nurse who has a lot of experience. So she explains him how to use creams, ointments, at what stage you should see your doctor, and all these kind of things. People really like this, and they say they get other information than they get from us doctors, as we have a different approach. Maybe they are also less shy to ask things they don't dare, although we try to be also open-minded. And of course, all big centers, we also offer outpatient clinics specifically dedicated to patients with AD, as we have learned that we need to have larger time slots than in the routine, where otherwise you see maybe patients with actinic keratosis or warts or something, which you can deal much faster than this. So we have also one hospital in Switzerland who is really dedicated for patients with atopic eczema and allergic asthma, where there's also a strong emphasis on nutrition, on psychosomatic aspects, and especially people who are really burdened very much about their disease. They benefit a lot from being 2 weeks there, and then they have an educational program in these 2 weeks. They all see the colleague from psychosomatics, everyone. So then there's not someone who feels offended by suggesting that there might be also psychological aspects. And this is a model which is covered by insurance if you have very severe AD. So that is an overview. This is the greetings from our team, again with masks. I'm in my office, that's why I'm speaking, and I'm happy to take your questions.
Thank you very much, Peter. I just have a short question about the educational programs that are offered for the patients. Do they pay by, for attending those programs? I know you mentioned if they can afford it, but how often do they volunteer to pay to attend a course on atopic dermatitis?
I must say that's about 90% of the patients say they are volunteering to pay. In Switzerland, it's more the time question, whether they say, oh, I don't find the time to invest it, but the money is not so much a problem.
Okay, I think we have a question for Sandra Soa. Yes. Oh,
it's a whole group, huh?
Yes. No, I don't think there's a question there. So, okay, Jean-François, do you have a question?
I think I visited Maya LHM in Rome last month, and also in Rome, the patient have to pay for education, and it's not so. It's already affordable. It's about 20 euro per consultation, but finally the result is positive because the patients are more involved in this process of education if they have to pay, because sometimes maybe I don't know in São Paulo, but in France sometimes we organize a workshop and finally we only have 2 people and in front of 1 nurse and 1 doctor, 1 psych. So it's not very efficient. So yeah. I think the cost of the education process is not a taboo for me.
What we learned also, at least maybe that might be a Swiss thinking, if it's fully free, people sometimes also think it's not having any value.
Yeah, sure.
Yeah.
I agree.
I think Gail raises her hand.
Thanks. You know, when I was working with leprosy in India, they always told us that you ask people to pay, even if it's 1 rupee. It somehow encourages that commitment towards whatever it is, looking after your shoes or coming back for your follow-up visits, whatever. But you don't have to charge a lot. It's just that it somehow is a measure of commitment.
Okay, thanks for this comment. Yeah, we also see it like that.
I guess this is one of
also show that at the end you save money, and some patients, they can request the money they pay from their health insurance, but it needs their effort.
I guess it has to do with cultural differences, because I think I'm not sure about if if this might be true, but if we charge for I agree that there should be some kind of co-payment for people to value this service that the person is giving, although the group is giving for the patient. But otherwise, I think that there might be people who think people are taking advantage, or the doctor who's organizing it wants to get money from the patient or something like that in those lines. So I guess there's still some cultural differences in each country.
Absolutely. Yeah.
So thank you very much, Peter. I would like to ask you to introduce Gail, because I know you're very connected to, and
yeah,
very nice.
I think it's a great pleasure and privilege to introduce Professor Gail Todd from South Africa, from Cape Town, who's many years led there the big dermatology unit, seeing patients from all ethnicities and also different socioeconomic levels. And I'm really happy that we have someone from Africa today, because very often it's the lost or forgotten continent. So I'm very happy that thanks to ISAT, we can embrace also Africa. And I'm very excited to see the aspects of AD in South Africa. Thanks, Gail, for joining us and for giving us your insights. We already see your screen, Organization of Care in AD in Africa.
Okay.
So it's all fine.
Okay, so can you hear me?
Yes, perfect.
Okay, perfect. Now, thanks firstly to everybody for giving me the opportunity to talk. I want to make it clear that I'm talking with apologies. I'm talking about a continent. Most of you are talking about a country. So there's a central government or whatever it is. I've got 55 countries, independent countries in Africa. So it's impossible for me to do that. So I thought that my job was actually made much easier by the ISAD Global 2019 Atopic Dermatitis in Sub-Saharan Africa meeting that was arranged in Geneva, which was set up by the ISAD to specifically identify what was needed for Africa. And they invited people from all over, and you've already seen a picture of the attendees who came from all over Africa. And that was the position paper that was eventually written, giving a roadmap and the current status. So I'm going to go through this and add to it, but just adding little snippets. I can't possibly cover everything from every country, but give an idea of what people in Africa have to deal with. But remember, I'm from the tip of Africa, and I really present this work with apologies because I'm not an expert on the whole of Africa. Before the Congress, Roberto did a survey of people to find out what was available for them to use. And I want to stress that it was really emollients, topical steroids, and oral antihistamines, which are the only things that are really available on the essential drug list from the World Health Organization. And then you can get some oral antibiotics and things to go with it. Methotrexate is the only other option for us to use that is readily available, but again, expensive because of the tests that are required with it. So talking of dupilumab is being launched in South Africa and in Egypt at the moment. But if you look at the data for it, there's been no African inclusions into the studies that are proving that it's of value. And really, the guidelines that are used throughout throughout Africa come from foreign countries, and South Africa has one which I was involved with the writing of. But again, it's based on foreign countries and foreign trials. So the recommendations that came out of this was that we needed to do Pan-African surveys comparing recommended diagnostic and outcome criteria and tools relevant to Africa. We needed to look at AD prevalences throughout Africa. We needed patient desires and needs to be firmly assessed in some qualitative way, not following questionnaires that have been put out in the north. We needed to know what education programs for skin diseases were there, especially for primary care. And then we needed to discuss emollients. Emollients of various kinds are used throughout Africa, some of which cause problems and some don't. So atopic eczema, I thought what I would do was just look at the issues that make atopic eczema different. So are the clinical features in Africa any different? And I think this review by you, which was published in the American Journal in 2019, has definitely come up with showing that the studies there's heterogeneity of atopic eczema across all countries. They picked up 78 different signs and symptoms, and notable differences by region and age group were picked out. Africa, they had 6 studies from Africa. And although the prevalent features were pruritus, lichenification, and xerosis, here on this heat map, you can see that there isn't a pattern that fits everybody. So what was found in Africans was that studies from Africa reported more papular lichenoid lesions, like I'm showing you here, palmar hyperlinearity, ichthyosis, and orbital darkening. However, one of the other features that doesn't come into many of these studies is that we find that it's extensor involvement in over 70% of cases from Nigeria in a very good study, and that the extensors tended to be mostly seen in the younger age group. They also reported in the same study that xerosis, periorbital darkening, papular lichenoid lesions, and palm hyperlinearity were the features, the minor features from the Hannafin and Reichert criteria, which were more likely to be seen in their patients. A study from Tanzania also found that eczema is more prevalent on the extensor surfaces in certain areas, but equally distributed between both. So it's not just a flexural problem in Africa. It is all over in Africa, involving extensors. They also showed that dry skin, infraorbital folds, hyperlinearity, papular lichenoid lesions, and periorbital darkening were features of their eczema patients that they showed. So knowing that we've got different features, and that's not all of them, what are the diagnostic criteria and scoring tools, and how relevant are they in Africa? Well, a validation of ISIC and UK criteria was undertaken in Ethiopia. And looking at these, it was found that positive predictive values were pretty low for all of the studies they did. Equally, in our study in South Africa, 3,000 general population, looking at general population, we found that the sensitivity and positive predictive values for the UK criteria and visible flexural eczema alone were pretty poor, although visible flexural eczema did work better. There's a recent study coming out of West Africa in which they compared SCORAD and patient SCORAD and showed that there was a good correlation suggesting that this might be a good tool, or these might be good tools to be used all over in Africa. So knowing that our tools are not necessarily 100%, what is the prevalence and incidence of atopic eczema in Africa? Well, in the study from Tanzania, they found that most of their children occurred in the lower age, were younger, and their prevalence was 5.2%, which is not very high. And this was a general population of children in a small village in Tanzania. The validation of the UK criteria in Ethiopian children showed a prevalence using the ISIC criteria of 4.4%, but only 1.2% using UK criteria. And in our own study, we found a prevalence of 1% as diagnosed by a dermatologist, 1.8% using visible flexural eczema, and 2.5% using UK criteria. So that depending on the criteria that's being used, so your prevalence and changes, and so does it change dependent on the population and what's where your population is based. The ISIC studies, probably the ones that are most commonly quoted regarding prevalence in Africa. You can see these were done in these particular countries. And they came up when in the study where they compared the two, the earlier one and then the later one, that atopic eczema is an emerging problem in Africa. There's some of them where you showed an increased prevalence. And then there are large variations within countries and centers in the same country. So we're not even talking about cross countries. These are within countries. There's large variations. They found that urban living and non-allergic factors might play a much more significant factor than elsewhere. So what are African atopic eczema triggers and risk factors? Following on the urban rural study and comment, there was a systematic review looking at rural and urban atopic eczema and the risk. And there were 4 studies that I've highlighted here that came from Africa. 2 of them, which showed very positive, eczema was much more common in urban groups Ethiopia and South Africa, but the other study from Ethiopia didn't show the same. It showed equivalent, so it's not 100% that urban living is the problem. If you looked at some of the studies from Ethiopia to look at what could be risk factors, we found that all the usual things that are shown at the bottom, family size, crowding, breastfeeding, income, education, had no effect at all on the outcome and the number of children that had eczema when they compared normals to controls. However, they did find that parasites, access to piped drinking water, fruit, and a history of having had malaria were more likely to be associated with atopic eczema. Again, different things that are being shown to be causing atopic eczema. In a study from Nigeria, they showed that the food intolerance, parasites in the stool, and HIV were not related to atopic eczema, but things like weather, heat intolerance, humidity, perspiration, grass intolerance, thick woolen clothing, stress, etc., was much more likely to be related to atopic eczema. What about filigran? There have only been 2 really good studies on filigran in Africa. One came out of South Africa, which we did not find a relationship to filigran mutations in our patients, although we did see some changes in natural moisturizing factor, and neither did they find that in a big study done in Ethiopia. However, recent studies from Ethiopia suggest that barrier function is important and that tight junction claudin-1 genes have been detected amongst atopic eczemas in people in Ethiopia. So then the other big group that I think that is important, that is always quoted when we're talking about atopy, is sensitization. I'm just going to mention 4 studies here. One was out of Uganda, where they looked at a birth cohort, followed them from birth to 9 years and above, and they did skin prick testing on them at 3 and 9 years of age. And if you look at the green and the gold bars, that's the mites were most commonly seen in both the 3-year-olds and the 9-year-olds, but the pattern changed as the children got older. And this is in keeping with life studies which have been done in other parts of the world, where even for individuals, your sensitization pattern changes with age and exposures. So a study done in Tanzania looked at adults with atopy, and they found that, again, house dust mite was the most commonly common sensitization in Tanzania, but things like birch, rye, and hazel pollen were also next most common, and yet hazel trees and rye and birch is very uncommonly found in Tanzania. So again, what does this mean when you transplant prick tests from northern countries to southern countries? What does it mean? In our own work with Peter, we did this work with Peter. We're looking at the molecular antigens. We again found that mites were the most prominent cause of sensitization in both cases and controls. But the interesting one for me was that we found that mouse lipocalin was more commonly found to be sensitized in atopics. And this and dog, you'll notice that dog and cat are not on this list of the top allergens. Again, interesting. Why should this be a feature that isn't reported from other parts of the world? Although I have seen it reported for cases of asthma in the USA. Again, the last study I want to look at here was a study looking at the sensitization profiles of 650 allergy patients, looking at the antigens and in comparing in Austria and in Zimbabwe. And you can see that the antigen that is causing birch pollen allergy is different in the African population to those in Austria, and a similar different profile of what antigen is being recognized in these by these different groups of patients that have been sensitized. So what about therapies then and their relevance in African patients? Having just told you that we have very limited access to treatment, and most of the studies don't show or don't include atopic eczema patients from Africa. The Kaufman et al. Did a study looking at racial differences in presentations and treatments. Oh, sorry. And they came up with this comment to say that if they looked at the representation of races in these clinical trials, there was definite groups that were not even included. And if they were included, they were usually the data was not analyzed relative to the results. As I told you, the work for dupilumab is coming into South Africa and into Egypt, but I think it's only been tested in Egypt. So it's a market that's going to be used, but there is nothing being drugged. There are no trials to show its effectiveness. And that's a bit worrying because the evidence that is used to drive guidelines and to drive the most appropriate treatment is often taken from those studies that I've just referred to, and they exclude many African publications because Africans and African work has often had difficulty getting published in mainstream journals. And my advice would be that African journals online should be included as part of, it's a huge database that should be included in any search engine that is going to publish a Cochrane review or any of those kinds of reviews. And that's the address for it. It's easy to get hold of and the data is easily available. It covers 523 journals, of which 253 are open access. And it represents 32 African countries and there are 55 on the continent. So what about education? Now, the challenges at our meeting in Geneva said, well, we need to look at education, and we took up the challenge and we wrote an article of all the education training facilities for dermatology in Africa, and it was published in the dermatology clinics. Interestingly enough, we have, on listening to the rest of you talking, it's quite sad, we have less than one dermatologist per million population. We have a huge need. We have a large number of kids and adults that need help with dermatology. We have only 25 out of 55 countries where we have training programs. And these programs are of international standard. However, training programs that are designed from the global north and transplanted into African universities emphasize practices which are not available, cost-effective, or based on evidence from Africa. And I say that these programs often reflect colonial roots and need decolonization to make them relevant to Africa, a call that is being heard throughout the universities of Africa. And I don't know if the people in the northern parts, the northern hemisphere or the global north is hearing them. So here you can see only these are less than 10 dermatologists per million of the population throughout the whole of Africa. And here are the training programs, mostly regional in West Africa and national with a sprinkling of university training programs. So what do African patients want from us? Maybe the African Society of Dermatology and Venereology, which is established in 2015, will provide a source for us to meet. But I want to end, and this is my last slide, to say that Africa is an incredibly rich continent. It's an incredibly rich for many levels in what the people, the cultures, everything. It doesn't have high-rise buildings and towers that beep at you and cameras in the street, but it's full of the most incredible resources. And this is just an example of an aerial view of a village. And when Europeans first came to Africa, they considered the architecture very disorganized and thus primitive, because it didn't fit the pattern that was in Europe, even though it was done according to careful rules of symmetry, proportionality, and repetition, now known as fractal design, a form of mathematics that hadn't yet been discovered. And this is repeated in the hairstyles of many Africans and in their textiles. So I encourage people to look at the cultures look at the other people's cultures. You can learn so much. And healthcare in Africa means that we need to take into account the family, we have to take into account the ancestors, we have to take into account the community. It's not just a pill for a patient. So thank you very much for your effort, for staying this time and for letting me go over time by 1 minute. I appreciate that. Thank you very much.
Thank you, Gail. We appreciate your contribution. I think that was really extremely interesting. Would anyone like to comment or to have questions for Gail? And we really gave you a challenging task. As you said, we all other could speak about countries, although Australia is maybe a little bit larger and also than Switzerland, but you had to cover all over Africa, which is of course a huge challenge, but I think you managed very well to give us the different aspects. Anyone who has a question or would like to comment?
I just have a comment about, what Gail presented about the fractal design. That's really interesting concept, and the value of community. And we have to go back to, in a way, we have to go back to that. And it has to do also with what Fiona talked about, the sense of community. It's not just the patient is isolated and taking a drug. It's about the whole support that the patient has to have from his or her community, that it's also important. So thank you very much, Gail. I would like to finish the session with just maybe a short panel discussion about what we discussed today. I know we're very short on time, but it was a fascinating session, to great opportunity to have colleagues from all over the world talking together and sharing these experiences. This such important, such valued opportunity for us to have this chance. So I know we're going through a pandemic, and maybe if you could, I don't know if this is something that we could discuss. I just have a question about if you noticed any increase either with vaccines or either with patients getting COVID, if you notice any flares or because I had some patients who contracted COVID, but I didn't notice that they complained. They had a different reaction to the disease, or even with vaccines. But I would like to know if you have any experiences as far as the COVID pandemic and atopic dermatitis. Does anybody want to? And not only the panel, but also other colleagues. Peter?
I can just say that we, like your impression, we had patients who had COVID, but they didn't react differently than others without AD, whether to the disease and the vaccine.
Any other colleagues want to comment on that? Okay. I think any other questions before we finish? We're about 5 minutes. So I would like to thank all colleagues, all the speakers who presented on this fascinating session. I'm really impressed by the colleagues from all over the world, from Africa, from Asia, even from Iceland. I understand we had somebody, and from Madagascar, from all over the world. And we started with a talk by John Su from Australia, which is a country that we don't have a chance of having too much information about how's the atopic dermatitis in Australia. So it was really interesting to see the educational programs, and also from Yoko and the story about the corticophobia. That was really interesting to see how that impacted the whole decade of 1990, and how she's doing a great job in dealing with the adult patients. And then we had the fascinating talk by Fiona and Marianne about mind lines and the 5 messages that Fiona found out that are very important in atopic dermatitis, and the Dragon in My Skin project, which we're hoping we'll be able to do it in France and in Brazil, and then hopefully to other countries. We have a lot of work to do next year, Marianne. And thank you, Peter, for the talk about AD in Switzerland, and Gail for the situation in Africa. And finally, thank Laurent, who's hidden somewhere. Thank you very much for the transmission. I think it went flawlessly this time. Thank you very much. It was really nice. Thank you for all the colleagues from all over the world.
Maybe I can say on behalf of the
yes,
ISET board, just a great thanks to you, Roberto, for organizing this meeting, for putting it all together. Of course, also to all the participants, but it was thanks to your initiative, the support of Laurent, and of course in ISET we are very much in favor. But our great thanks to you. I think I'm speaking for all the participants.
Thank you, Peter.
Thank you very much. Thank you very much. I think we have to education and all these different approaches, they have to be complementary to the traditional therapeutics in atopic dermatitis. So we have to continue doing these meetings, and I thank the ISET for this great opportunity. So see you all next year, I guess, and we're looking forward to the next ISET in Canada. I see Danielle Marcoux is here, and we're looking forward to being in Montreal, Danielle. So see you all. Have a great Christmas, great New Year's, and we'll keep in touch. Take care, everybody.
Take
Thank
care.
you very much.
Thank you.
Bye, everyone.
Thank you
very
very
much.
much.
Looking forward to see you in Montreal.
That's
Yeah,
it.
we will
Danielle.
join you.
See you.
See you.
See you soon. Bye.
Bye.
Bye.